Okay, well, a very good afternoon to everybody on this Teams live link, and welcome to the annual general meeting of Northern Lincolnshire and Goole NHS Foundation Trust. It's our annual members meeting. Everybody's very welcome. My name's Sean Lyons, and I'm the chair of Northern Lincolnshire and Goole NHS Foundation Trust, as well as being the chair of Hull University Teaching Hospitals. And both of those trusts are part of the newly named group called the NHS Humber Health Partnership. So this is the sovereign organisation, South Bank Sovereign Organisations annual general meeting, and everybody's very welcome. So may I just start off by just going through a couple of points of housekeeping. This is a Microsoft Teams live event, and so just to mention how people can participate in this. People won't be able to live speak their own questions, but if people have got any questions they want to raise, please do so by clicking the Q&A box at the top of the screen. You'll be able to put in your question. Please, if you can, identify yourself whilst you're doing so that if we're not able to answer the question in the moment, as it were, we'll be able to get back to you outside of the meeting, and so we won't lose that connectivity. So please put your name and the question in the Q&A box, and we'll try and answer them as we go along. But if we're not able to do so, then of course we'll come back to you, providing we know who you are. So, and you'll see the questions as they come up in the live event Q&A. So, and we'll stop at the end of each section of this this meeting to be able to just make sure people have got time to put their questions in. So today you'll be hearing from a number of speakers, and we'll be looking back at 23-24 in terms of our operations and our financial performance, what our audit report said during for the last financial year. And then we have, we're delighted to be able to welcome Diane Lee, who is the Director of Public Health in Northern Lincolnshire, which covers North Lincolnshire and North East Lincolnshire. Diane's going to be able to give us an overview of public health in Northern Lincolnshire, which I think all members and attendees will find very interesting. So we're looking forward to Diane's celebrity speech, as it were, a little bit later on in the meeting. We've got an item on governor elections, which is very live and current, and Alison Hurley will take us through that, and then we'll sum up at the end and have a final round of questions from anybody on the line right at the end. So hopefully that will be a very interesting agenda for those on the meeting. Welcome again to everybody on the screens and listening in, and we'll move on now to the first part of the agenda, if that's okay, which is for Jonathan Lofthouse, our Group Chief Executive, to take us back a little bit through the last year and to look forward to where we're going in 24-25. So over to you, Jonathan. Thank you very much.
Chairman, thank you. Ladies and gentlemen, colleagues and friends, very good afternoon. Thank you very much indeed for joining us for our annual general meeting, which for many of us isn't just a look back, but it's also a celebration of many of the progress and successes that we've achieved over the last year or so. I'm just going to speak briefly for about 10 to 15 minutes and take colleagues, partners, members through some of our reflections, some of our progress, both as an organisation and on behalf of our patients. So we'll move on to the next slide, please, Sam. So over the last financial year, the 23-24 financial year, we've had quite a degree of change, positive progress, and celebration. So let me start just by paying reference to my predecessor, Dr. Peter Redding, who moved from the organisation, having been Chief Executive of North Lincolnshire and Goole NHS Foundation Trust for around about 5.5 years. Peter moved out of the organisation to take further Chief Executive last summer, but not before, along with the executive team and the wider organisation base, had successfully moved the organisation out of both quality and financial special measures. Through under Peter's stewardship, the organisation had really spent a number of years responding to the needs of its patients and improving the quality and financial stewardship of services offered across the South Bank of the Humber. I myself joined the organisation in August of last year, and in so doing took over the reins from Peter, moving forward the organisation. So since joining the organisation last summer, we've undertaken quite a number of significant steps, bringing about closer unity and harmonisation with Hull University Teaching Hospitals NHS Trust, our North Bank partner. And along with the chairman, as reflected, who provides joint chairmanship over both organisations, I too provide joint stewardship as the accountable officer for both organisations. So since coming together last summer, we've introduced both a trust board and a committee structure in common, which means that for business issues, we look at business issues pan-organisation, both for NLaG and for Hull University Teaching Hospitals in one single sitting. So we have a board system in common and a committee in common, and the committee in common is made up of a number of subcommittees providing stewardship around quality, finance, capital investment, audit and review. We've also harmonised and brought to scrutiny the executive operating structure and operational structure of providing services to our patients. So we now have one single executive team providing services across both of the two sovereign organisations, NLaG and Hull University Teaching. And those executive directors spend an equal amount of time on both the North and South Bank, and our working days and working weeks very much reflect that, with all of the executive team rotating across all aspects and sites of our organisation to ensure that senior leaders, staff, patients have both access, visible access, direction, nurture and leadership from operational senior leaders who are present and visible and contributing and connected. Possibly one of the most significant changes we've made on behalf of our patients is the harmonisation and the establishment of our 14 care group structure, Humber, pan organisation. So in very simple terms, by clinical modality discipline, the senior leaders of those clinical disciplines now are the senior leaders wherever the service is provided. So as a very simple example, if you're a patient requiring orthopaedic care, the operational structure is in charge of orthopaedic services wherever they are provided across our conurbation, be that at Grimsby, at Scunthorpe, at Hull Royal Infirmary, or at Castle Hill Hospital, or indeed as an outreach at Goole Hospital. And that's the same for every area of clinical service. So we have harmonised every single clinical service. We've embedded them within a 14 care group structure, and each of those care groups is led by a senior clinician, a chief of service. We adopted that model because we wanted to strengthen the clinical voice within our operational services, ensuring that the clinical voice is well and truly heard by the executive and the trust board, allowing us to progress, amplify and build on the quality of clinical services for the good of our population and our wider stakeholder base. And as the chairman's reflected, we also, as part of our harmonisation and identifying more wholesomely as one larger organisation introduced a group name, NHS Humber Health Partnership. So that doesn't erode the sovereignty that currently exists within Northern Lincolnshire and Goole NHS Foundation Trust, but it allows us as an organisation to identify outside our local system nationally with the Department of Health through one signal nomenclature, and it allows all of our staff to identify not only with a local site, but as part of our wider hospital group. And in so doing, brings about cultural change and cultural harmonisation. Next slide, please, Simon. So since coming together as a group, we've made a number of changes, as many of you will be aware, and many of you have been a part of, including many of our governors and partnering members. We thought it was really very important for us as a new organisation, as a group organisation, to set about clarifying a new vision statement and a new set of values for the group organisation. And that's in no way to suggest that there was anything wrong with the historic values that had been permeated through Northern Lincolnshire and Goole NHS Foundation Trust, but more a step of further harmonisation, taking the workforce from Northern Lincolnshire and Goole and the workforce from Hull University Hospitals. Collectively, that's around about 19,500 skilled individuals, and allowing those individuals to come together and unite behind a clear statement of purpose that we can really start to bring in for cultural benefit across our wider organisation. And in so doing, we also worked with and co-developed with staff our new values: compassion, honesty, respect, and teamwork. And on behalf of the wider community served by Northern Lincolnshire and Goole NHS Foundation Trust, a number of out-of-hospital stakeholders, along with governors and partner members, were involved in the developmental sessions, the workshops, question and answer sessions, from which these new values and the new vision statement were born. So on behalf of the chairman and the wider board, our thanks goes to governor colleagues and partners for their contribution and continued support over the year as we start to build through and frame our new culture, our new vision, and our wider strategic aspirations. And just on the strategic aspirations, earlier this calendar year, a couple of months ago, July this calendar year, we launched our strategic framework. Our strategic framework providing the building blocks from which we, as Northern Lincolnshire and Goole NHS Foundation Trust and Hull University Teaching Hospitals, will start to pull together absolute clarity of our ambitions for our patients, for our service users, and for our staff over the next 3 to 5 years. Now, that is very much still work in progress, and we will be interacting in numerous forums with governors, neighbourhood groups and partner members as we move forward. But in essence, the majority of our focus is around responding to the health demographic need that persists across all of our conurbation, strengthening the high octane services and the specialist element of service, whilst ensuring that the nature of district general services provided throughout all of our population base are of the highest possible quality, are responsive, and are easily accessible. So it really strikes a chord to the communities that we serve through North Lincolnshire, North East Lincolnshire, and the Goole conurbation, but also East Ridings and the City of Hull. Next slide, please, Simon. So in terms of developing our strategic framework, the strategic framework from which we will build our 5-year strategic aspirations. We've been really very clear, and this pictorial demonstrates to all present the focus that we are applying and how we structured the focus. So first and foremost, it's around us providing excellent care for what we recognise as a highly diverse population. But more fundamentally, it's around us as an acute and community provider, enhancing and enabling the support to our population to live well, live healthy, and live longer. Built from the values that we've just spoken around, but concentrating on equity, on partnership, on innovation, and on the realities of care, the realities of how we look after the 1.7 million population that our wider group serves across this peninsula. It reflects the drivers that we will start to build progress from, driving improvements both in quality, service provision and innovation through our people, our clinical performance, our quality and safety, our research and innovation with industry partners, and our wider partnerships. And it will take us through a range of investments, not only in the cultural space and in the leadership space, but also technical infrastructure investments such as digital. And ultimately, it's very, very much my own focus and the focus of the chairman and the board that over future successive years, we bring back through the annual general meeting and other conversation forums, a celebration and a clear articulation of the progress that we're making against this strategic framework for the good of our population in terms of service efficacy, service quality, and ultimately service stewardship as a provider of public services. Next slide, please. Our most significant resource, the most significant resource that we have to direct to bring care to our patients is clearly our excellent workforce. And when we look at Northern Lincolnshire and Gould NHS Foundation Trust in isolation, that's a workforce of around about 6,500 professional committed individuals working across each of our 3 core sites, Grimsby, Scunthorpe and Goole, but also wider across our community range of services. And with our staff collectively and building upon the values that, as I said, were co-created by our wider workforce, our governors and our partners, we've identified a range of behaviours which both staff independently and more specifically our patients should rightfully expect to see demonstrated by every one of our workforce. Ultimately, the aspects with which we all expect to be held to account, held to challenge as public servants to our patient and population group. As you can see, they're very clear. They're appropriately simple through design, but the aspirations are absolutely appropriate. Next slide, please, Sam. So as we move more into an operational focus of our conversation this afternoon, I just want to reflect a number of the performance volumes and performance challenges that we continue to respond to. And I know many governor members, many members of the public, many partner agencies are often quite interested in understanding some of the pressures and impacts upon the hospital. Now, we've spoken previously in numerous forums and over the last 18 months or so around some very distinct effects coming out of the international COVID pandemic. And some of these issues, even though we're possibly 2 years post the peaks of COVID, still tend to wash out in patient impact and behavioural change that affect health services both nationally and internationally. As you can see from the slide, across our South Banks, we're seeing more patients through our emergency system presenting to our urgent treatment centres and to our emergency departments at both Grimsby and Scunthorpe than we have in previous successive years. And that is a aspect that is recognised in other health and emergency systems UK-wide. Following the peak in hospital admissions, it was slightly skewed in 22-23 because of the tail end of COVID. We're now starting to see a little reduction and signs of a return to what we would consider internally to be a normalisation of patient volumes. In terms of outpatient appointments and attendances, following backlogs that were created, again, UK-wide from the pandemic, we've started to make significant inroads in patients waiting for new outpatient appointments and through our outpatient services. And that's been aided by the introduction of outpatient alternatives to face-to-face, such as patient-initiated follow-ups, virtual clinics, telephone clinics, and team clinics. The overall reflection on newborns and birthing rates continues to reflect the England change, which is a continued reduction in the range and number of births. So we provide birthing services both in community, a small service at Gould District Hospital, a service at Scunthorpe Hospital, and a slightly more significant scale service at Grimsby. But UK-wide, all centres are seeing a reduction in births. So whilst the numbers there go down, clearly that's nothing that we as a hospital can influence, and it is part of a new UK norm. And finally, from this slide, I'll just draw attention to the last aspect. The number of elective operations within theatre continues to rise, and that's again as we respond to both need and backlogs in delayed care following the pandemic. So we continue to maximise our elective operating potential across all of our sites, and that increasing number as far as the organisation is concerned is actually beneficial. It is nothing to be concerned about. Actually, we will be very happy if that number continues to grow, because it means we're treating far more patients in a far more timely manner and providing definitive care for those patients. Simon, next slide, please. Overall, and this is reflecting our 23-24 operating year, just to remind participants and colleague members, our emergency department performance over that period of time was below the national standard, but has over recent months continued to grow. So the slide reflects a full year 12-monthly performance of around about 63% We've moved forward from that position, and at the moment, over the last several months, most days of the week are performing in the 70%. We continue to provide mutual aid both within our own conurbation and to neighbouring systems, and that mutual aid is in response to long waiting patient needs following the pandemic. And we continue to have strong financial stewardship. So as a sovereign organisation, and in a little while you'll hear some of the specific financial information from Philippa Russell, my colleague, but we continue to work diligently to maintain strong financial stewardship across the organisation. And in so doing, we continue to tackle long waiting patients, but need to do more, it would be fair to say, on our 4-hour performance, improving ambulance handover times and our cancer treatment times. And whilst this is incredibly important for us and our patients, it also reflects a very similar position nationally of hospitals recovering from the stresses and strains that were present across 2022, 2023. Simon, next slide, please. So in terms of just celebrating a number of really significant milestones and recognising some of the celebrations that we've spoken around, we opened earlier this year the new emergency departments, acute assessment units and same-day emergency care centres at both Grimsby and Scunthorpe, and collectively that was an investment of over £47 million in state-of-the-art accommodation, equipment and enhanced staffing numbers to provide that urgent and emergency frontline care to the populations we serve locally. We started the build work on developing our community diagnostic centres in Grimsby and in Scunthorpe, and those two centres, major centres, local to the population, so they're not on the hospital site, they're in the Grimsby shopping centre and in the Scunthorpe town centre, will come online providing high-octane diagnostic services to patients and GP practices in October this year, so in just around about 5 weeks' time. And that will provide a turbocharging of diagnostics for patients who may require MRI, CT or plain X-rays, may require blood tests or other forms of diagnostic testing as part of their clinical pathway. Earlier this year, in the spring of this year, we introduced a new patient administration computer system to Northern Lincolnshire Ghoul NHS Foundation Trust, and this very much provides a platform from which we can build further clinical pathway harmonisation between the North and South Bank, allowing NLaG to transfer patients who might require specialist services that are only available on the North Bank, so some of our high-octane cancer, cardiac and neuro services, as seamlessly as possible. So our new patient administration system is live now, but will continue to develop over future months and years as we harmonise clinical pathways of care. And we also completed the Humber Acute Services formal consultation. This is a consideration that has been shared and spoken about in a number of forums for around about 18 months, and very much centres around enhancing the pathways of care to patients across the North Lincolnshire and East Lincolnshire Peninsula, ensuring that services are safe, are well structured and of the highest quality, and where that's not the case, consolidating and bringing together services to make them larger and stronger, whilst no less accessible to the patients that we serve. So the consultation around those service changes has now formally closed, having been part of a national process, and over the next 6 to 18 months we'll be making a range of improvements and transfers and changes to service, enhancing both local aspects of care, but also enhancing more sub-regional aspects of service delivery. So Simon, if you take me on to what I think is possibly my final slide, please. So as we move forward this financial year, and the considerations that myself, the board, the executive team and operational leaders continue to shoulder into, we need to continue our focus on improving the quality and accessibility of service provided to our emergency and undifferentiated patients, and in so doing, enhancing our emergency care performance and our relationship with ambulance service providers, and that's East Midlands Ambulance Service and Yorkshire Ambulance Service predominantly. We will continue to make significant inroads, both to the speed and efficacy of cancer services, but also in responding with improved elective volumes to address the elective waiting list position. We'll start to move forward cross-conurbation, both as Northern Lincolnshire Ghoul NHS Foundation Trust and Hull University Teaching Hospitals, with our procurement of a single electronic patient record system that will take us around about 2 years to fully introduce and make live, but ultimately that will deliver an enhanced clinical structure of pathway management and safety for all patients wherever they present within our system, and be accessed by every clinician within our system. And we will continue to build on really significant improvements in the recruitment, retention and leadership development of our staff, whilst recognising the health and well-being of our workforce, working in what is undeniably a very pressurised, stressed and strained national environment. And we will continue to be good public servants and ensure that we spend the public pound wisely as part of our financial process. I think, Simon, that may take me to my last slide. So I'm very happy to respond to any specific questions in the chat. I know we've had a question raised around pension rights. So let me respond to that briefly. So because both parts of our group organisation, Northern Lincolnshire Ghoul NHS Foundation Trust and Hull University Teaching Hospitals, are formal NHS organisations, we've not outsourced any workforce, we've not changed baseline terms and conditions within Agenda for Change or within our medical body. There are no changes to any of our 19,000 staff's ability to access NHS pension rights, retirement issues or payments, sickness or ultimately death in service payments within the new organisation moving forward. So none of our staff have any reason to be concerned that their basis of employment has changed and had an effect on their rights of pension or service privilege. So I'm going to pause at that point. I'm very happy to support further questions and answers as we move forward with the conversation this afternoon. But I'm now going to pass to my colleague, Philippa Russell. Philip's the Deputy Chief Finance Officer for our hospital group for NHS Humber Health Partnership. And Philippa, over the next 10 or 15 minutes or so, is just going to highlight one or two of the interesting aspects of our financial management and stewardship. And then I'll come back and speak to you a little bit later on in this afternoon's conversation. So Simon, thank you very much. Thank you for listening, colleagues and friends, and I'm going to pass you to Philippa.
Yes, thank you very much, Jonathan, for that introduction. So I'm fairly new to the organisation, just been here 2 months. So this is my first annual members meeting, so very happy to be here with you. Would you like to move on to the next slide? Thank you. So our independent auditors report for this last financial year for 23-24 was a very positive opinion as described below. So it gave a true and fair view of the financial position of the trust, of its expenditure and income for the year then ended. It was properly prepared in accordance with the Department of Health and Social Care Group Accounting Manual, and it's been prepared in accordance with the National Health Service Act. So we achieved all of those ticks. The basis for that audit opinion was that the audit evidence was sufficient and appropriate to provide a basis for their opinion. And from a going concern perspective, the auditors did not identify any material uncertainties relating to events or conditions that might cast significant doubt on the Trust's ability to continue as a going concern for at least 12 months. So that's the kind of technical bit. From a financial position perspective, the Trust achieved its control total in 23-24, which was a break-even plan. In the end, we ended up with £125,000 surplus, which was an improvement. As this slide shows, the deficit as per the accounts was an £18.6 million deficit, but those are technical adjustments that are not included when we assess our control total. They're impairments and donations and Department of Health procured inventories that we can exclude. So if you exclude all of those, we come back to £125,000 surplus. Next slide, please. Thank you. So just to go back to last year and the financial regime and explain how it all worked. We continued with a block funding arrangement for both non-elective and emergency care, which included inflationary uplifts. Planned care did move to a more variable contract, with the elective recovery funding in particular continuing to incentivise the delivery of elective activity, aiming to reduce our waiting times. So that elective recovery fund was based on 1920 activity levels, so pre-COVID as our baseline, with the aim of us getting back to a pre-COVID level and exceeding that. We did still continue to get some COVID-19 block funding, but that was significantly lower than we'd seen in previous years, and that's generally being phased out gradually. And we continue to get pass-through funding for NHSE high-cost drugs and devices where appropriate and where on the correct list. Thank you. Next slide, please. So where did our money come from last year? In 23-24, we had £574 million of funding. As you can see from this little pie chart, the vast majority of that came from the Integrated Care Board. That's to £482 million. We did get a fair chunk from NHS England, around £40 million. A lot of that will be those pass-through drugs and devices. We continue to get some provider-to-provider income where we provide services to other NHS organisations. And around £20 million worth of education, training and research. Other funding streams are relatively insignificant, but we do get some funding from car parking, accommodation and other sources of funding. Next slide, please. From an expenditure perspective, we spent £588 million last year. As you can see, over 2/3 of that was spent on staff and salaries at £496 million. We spent nearly £100 million on supplies and services, quite a high amount on clinical negligence. That's our insurance, in effect, that we pay out every year. And we also had some costs for, obviously, premises, around £22 million, depreciation, establishment and transport. The impairments, which I mentioned on the previous slide, are just a technical adjustment relating to the valuation of our assets. And that was £17.6 million last year. Next slide, please. So the trust asset base was £294 million. So that's based on a desktop revaluation that we did from an independent valuer last year. £266 million worth of our assets are owned by the Trust, but we do also have some donated assets and some leased assets, which are also shown on that pie chart. The majority of our owned, oh, sorry, you can't go back, can you? The majority of our owned assets are buildings and plant and equipment. But we do also have some intangible assets, which is the software and bespoke IT applications that we've invested in over the last number of years. And you can see that we do have quite a lot of assets under construction, in particular those community diagnostic centres that we mentioned that were in progress at the end of the year. Next slide, please. So this is a bit of a list of our investment in infrastructure. So in the last financial year, we invested £49.4 million in both property and equipment. You can see there was over 15 million spent on the community diagnostic centres. There was a massive investment in emergency departments and the acute assessment units that Jonathan mentioned earlier, 13 million. And we also spent on some smaller projects, including an MRI at Scunthorpe, fire alarms, backlog maintenance, which is just the ongoing maintenance of our various hospitals, and quite a big investment in IT as well. Next slide, please. So the Trust has 2 capital loans outstanding at the end of the year, a total of £6.9 million. Those are due for final repayment by the end of November 2029. Next, please. The balance sheet did improve over the last financial year. Our non-current assets, so that's our land and buildings primarily, increased by 15.3 million as a result of all that capital spend I've just shown you, and we did incur slightly less depreciation than we have done in previous years. The cash balance remains stable at £41.2 million, although a lot of that was due to a delay in capital spend. So we will be expecting to see some of that go out in cash terms over the next few months when those invoices become due for payment. Our borrowings reduced from 8.2 to 6.9 million, reflecting those in-year payments on capital loans, and our lease liabilities also reduced as a result of payments in year. The public sector payment policy, we did manage to maintain a reasonable performance against that, with 96% to non-NHS suppliers and 95.3% to NHS suppliers. So good performance on that side. Next slide, please. So looking ahead, whilst I've just told you that we maintained our control total and a break-even position, we did actually have an underlying recurrent deficit position that was assessed at around £50 million. And that, whilst it's improved marginally as at August 2024 to about £46 million, it is still a significant concern. The reason that we have that underlying deficit is that a lot of the things that we used to achieve our plan last year were non-recurrent in nature, so they don't support us in the future. There were a lot of non-recurrent savings. We also relied on a number of technical savings, and we got some non-recurrent funding that might not come again. For example, depreciation funding. There were also a number of recurrent investments that were made which didn't have the equivalent recurrent funding, and that did also impact on our underlying financial position. Next slide, please. So again, looking ahead to 24-25, we've agreed a deficit plan of £14.9 million at the start of the year, but this is part of a much bigger deficit across the ICB and across Humber Health Partnerships. So across Humber Health Partnerships, we have a challenge of £28 million deficit, and across the ICB, the plan is to achieve a £50 million deficit. I say achieve because in order to get to that £50 million deficit, the system needs to deliver £235 million worth of cost improvements, which is an absolute huge number. And the Trust's individual contribution to that requirement is £37.5 million. So we have to find cost improvement plans of that level to achieve the planned deficit. If we don't achieve those recurrently, that will again add to our underlying financial position. We have a capital allocation for this year of £39.3 million. That includes a large amount towards the community diagnostic centres and also some IT projects, including the electronic patient record that Jonathan mentioned earlier, and also pathology systems management programmes. There are significant risks elsewhere in the ICB as well, and overall that might threaten the achievement of the overall deficit total. We're not yet clear what that might mean for individual organisations if the ICB as a whole doesn't achieve its control total, even if this particular trust does. So that's something to be discussed. So key financial risks. The delivery of the Trust's financial plan is considered extremely high risk. The magnitude of that efficiency plan is the most challenging aspect within this. We are developing and managing those efficiency programmes through a newly formed Financial Planning Improvement Board, which is chaired by Jonathan, the Chief Executive. And within that evolving programme, there are a number of key risks. In particular, we are aiming to deliver significant additional elective activity through productivity gains, which will generate additional income for us. In particular, convert follow-up outpatient appointments to new appointments, which is cash earning. Follow-up appointments currently do not fall into the variable element of our elective income. We're also aiming to deliver length of stay reductions for our acute patients, in particular improvements to those with no criteria to reside, which might enable us to reduce some of our staffing costs. Finally, we need to match our long-term health needs of the population to the services we deliver as a system. And the Humber Acute Services Review process is now coming into its final phases and needs to be concluded. Probably the largest risk is not necessarily a financial one. It is a complete change of mindset that we require in order to deliver such a sizable efficiency programme. It's not a case of just finding housekeeping improvements. We need real transformation and real change if we're going to achieve such a big financial target. So that's the end of my part of the presentation. I'm happy to answer any questions. Just have a look and see if there are any in the chat.
Thank you, Philippa. I don't think there's any direct questions for you so far. Correct me if I'm wrong here, Aid and Simon. There's a question about group priorities and issues about, this is from Mike Bateson, about how are we going to improve for our emergency care and cancer treatment performance in the context of the current challenges that we have. That's one question for you, Jonathan, and another one from Mark Branton, which is about Health Tree Foundation. I'm not sure whether, Mark, you mean will the Health Tree Foundation continue, but your wording is continue to succeed. So perhaps, Mark, you might be able to clarify that question, if you wouldn't mind, please. But Jonathan, have you any comments for Mark Bateson on the 4-hour emergency care and cancer treatment plans, please?
Chairman, thank you, and thank you for continuing to post questions in the chat. So Mike, thank you. So Mike's question is around our improvement plan for our emergency care and continued challenges. So as I reflected, whilst over the 22-23 operating year, our emergency care performance was around about 63-64%. So far this year, across both Grimsby and Scunthorpe, we're now in the mid-70s, it's early to mid-70% in terms of emergency performance. And in very many aspects, this is around our improved and changed model of care. So within both of our new emergency care centres, we have a blend of both urgent treatment facilities, standard emergency department facilities, and then short stay intensive assessment facilities. And it has been found nationally that by co-locating the spectrum of emergency model, you can make greater inroads and pump prime, if you like, the speed with which we can respond to emergency and undifferentiated patients. But it's also important to recognise that whilst the actual performance is often allocated to the acute system, the strength of emergency performance is a pan-health economy issue. So for us as a system to have strong, high-performing emergency departments, we also need high quality, easily accessible GP services, as an example. We need pharmacy services that are accessible to the public. We need the public to be using 111 services for health issues that don't require an acute hospital presentation. So what I would say is our clinical model continues to evolve and evolve very well. Dr. Anwar Qureshi, our Chief of Service for our emergency service care group, continues to work with and through all of the emergency department staff in enhancing the emergency quality aspects for our patients. As I say, we're now treating patients around about 71, 72%. But no less, we need to continue working with and through health partners, both in the hospital and beyond, and with the ambulance service, to sustain and bring about continued improvement. With regards to the challenges of our cancer treatment piece, if you look at cancer treatment as a diagnostic element and then potentially an operative element of a pathway, as we bring on board the new community diagnostic centres, which, as I've reflected, will be coming on board both in Grimsby and Scunthorpe during October this year, we will start to be able to diagnostically assess at a far greater pace patients who otherwise might be waiting for elements of cancer diagnostic. So the very sizable investment that we've made and continue to make in our wider diagnostic pathway will have a direct impact in the pace and speed in which we're able to take forward our cancer treatments. So whilst the challenge continues around finance and strong financial stewardship, as Philip has just reflected, we have made significant inroads into stabilising staffing. And as we go into the winter months, around about November, December this year, we will be technically fully established for registered nursing posts across all of our South Bank sites. So we'll have far less reliance on a commercial agency, far less reliance on bank, and therefore far greater financial spend control and far greater ability to enhance the quality of care provided to patients. And just briefly, in response to what I believe is Mark's question with regards to the Health 3 Foundation, at this point in time, both sides of our group, so Northern Lincolnshire Ghoul NHS Foundation Trust and Hull University Teaching Hospitals, have separate charities supporting their endeavours. And at this point in time, there is no suggestion that that will change. So we would fully anticipate continuing to maintain the really excellent relationships that we have with the Health 3 Foundation, who bring about financial cost saving and charitable donations to all three of our Northern Lincolnshire and Gould sites and our community service, Mark. So I hope that answers your question. I'm going to pause at that point.
Thank you very much, Jonathan.
Questions, but please keep posting them in the chat and we will happily come back to them in a few moments. And I'm going to introduce colleagues to our external partner colleague, Brian Kirkland, who represents our external auditors. Brian's going to talk to you around the external audit opinion for Northern Lincolnshire Ghoul NHS Foundation Trust, and is also just going to make a brief comment because his own firm have very recently changed their operating name. So not to confuse anybody, but Brian's now appearing for a different company. It is the same company with which we've had a relationship for a period of time, but I'll let Brian explain that. After Brian's spoken with you, Brian's going to pass back to myself one more time. So Brian, thank you very much.
Thank you, Jonathan. Good afternoon, everybody. Yeah, so this is the annual audit report for 23-24. That's the public-facing document on the outcome of the audit. As John has mentioned, this is my second year of being your external audit partner. We have changed our operating structure and our brand to Summer Audit for NI, but the audit team was exactly the same team as the previous year. So we'll just move on to the next slide, please. Super, thank you. So in terms of the outcome of the audit opinion was issued on the 9th of August, in line with the timescales agreed with NHS England. And that was the second year on a 3-year journey to get NLaG back to a reporting and having their accounts audited by the end of June. So next year we'll go back to the normal end of June 2025 deadline. The audit process went well, and on the basis of that, I'm very confident in terms of the ability to report on timescales next year. My thanks go to the previous CFO, Lee Bond, and Sally, and all the rest of the finance team involved in the audit process. We issued an unqualified audit opinion on financial statements. Paul has touched on that in her presentation. But in layperson's terms, that means we're comfortable that the income and expenditure presented in the annual financial statements are fairly stated, and that the assets and liabilities presented in the balance sheet are also fairly stated. There is a requirement on NHS body auditors to also provide a commentary on the value for money arrangements within NHS foundation trusts. And in our report on that, it didn't identify any significant weaknesses. And as auditors to NHS foundation trusts, we also have a range of other special powers where we're required to report by exception on a range of various other matters, but no such matters arose that require us to report to the board, to yourselves as the AGM, to funders in terms of NHSE or to any other stakeholders. So overall, a clean audit opinion, and no issues to draw to the attention of any members to the AGM. So with that, I'm happy to take any questions if there are any. Just in terms of the next slide. And if there are not, I'm happy to pass back to Jonathan to introduce the next speaker today.
Brian, thank you very much indeed. So, partners and colleagues, if you continue to consider any thoughts or questions and post them in the chat, either to Philippa or to Brian, we'll be very happy to bounce back to them in a little while. So our next presentation is going to be from Diane Lee, our public health colleague. But before we come to Diane, I know the chairman would like to make just one or two reflections. So Simon, if we may, I'm going to ask you to take the camera from myself to the chairman, and the chairman will just make one or two reflections, and then the chairman will bring Diane into the conversation, please. Thank you.
Sorry, Jonathan. Sean's just not on camera at the moment, so I can't pass over to him. Sorry.
Oh, bless him. Not a problem at all. Not a problem at all. So allow me to just pick up that. I think in a few minutes after we've heard from Diane, our colleague, the chairman's just going to square down one or two technical pieces of this afternoon's meeting for the record, in terms of noting apologies for absence for the minutes and one or two further technical aspects on behalf of the Council of Governors. So it gives me great pleasure as a embedded partner within our health and social care system. To invite to presentation our colleague Diane Lee. Diane's the Director of Public Health for both the North Lincolnshire Council and for North East Lincolnshire Council. And Diane's going to take partners, colleague members through a range of reflections looking at some of the out of hospital drivers affecting our population base in terms of health and healthcare aspects. You're more than welcome to pose questions to Diane in the chat, and we'll pick those up at the end of Diane's presentation. And then following Diane's presentation, we'll be passing back to the chairman just to cover off the technical aspects of the meeting before the chairman then passes to Alison, our Deputy Director of Assurance. So Diane, thank you very much indeed. Hopefully you should have a red box appear around your photograph in a second, which means that you're then live on camera.
Thank you very much. It's great to be here this afternoon. Yeah, my name's Diane Lee. I'm Director of Public Health across Northern Lincolnshire. I have been in post just over 11 months now. I still class myself as being fairly new, but I won't be able to do that for much longer, I don't think. The first thing I want to say is just thank you for the invitation to present this afternoon. And I've been asked to talk for about 30 minutes. I'll try and get through the slides in a little bit quicker than that, but to focus on some of the public health challenges that we're facing across Northern Lincolnshire. I have got quite a lot to cover. I've got quite a few slides, some of which I will spend longer on than others, but I'm really happy for the slides to be shared afterwards. And I really would like to keep the conversation going in terms of our collaboration moving forward. So next slide, Simon, please. So I thought I'd just start off really quickly with a couple of definitions about what public health is. The first sentence on the slide there is widely used by the Faculty of Public Health, the science and art of preventing disease, prolonging life and promoting health through the organised efforts of society. So that's one that we tend to use quite often. But the third bullet point on that slide is one that's really important for me. And that's about recognising that the choices we make, which affect our health and well-being, are constrained by where we live, the resources that we have, the education that we receive, the skills we learn, our friends, our family and our community. We all have free choice, but some people's choices are more limited than others. And that's something that I will focus on this afternoon in the context of the inequalities that many of our residents are facing. Next slide, Simon, please. So in 2010, Michael Marmot conducted a review of health inequalities in England, and that was called Fair Society, Healthy Lives. Many of you may have come across that report, also known as the Marmot Review, and he included 6 recommendations that we need to tackle as a system in order to improve health. That's giving every child the best start in life, enabling all children, young people and adults to maximise their capabilities and have control over their lives, to create fair employment and good work for everyone, to ensure a healthy standard of living for everyone, creating and developing healthy and sustainable places and strengthening the role and impact of health prevention. And those 6 recommendations all have equal importance if we are to improve the health and well-being of our population, and it was great to see that reflected in the slides earlier this afternoon. Next one, please. Unfortunately, 10 years on, Professor Marmot was asked to conduct a follow-up review, and unfortunately, and that's not a strong enough word really, poor health and socio-economic inequalities have increased as a result of austerity, as a result of some public spending reductions. And that's something that we all need to tackle together. Next slide, please. So now I've set the scene in terms of what public health is. I am going to run through some data as quickly as I can. I'm not going to read through these slides, please don't worry. Share them afterwards. If you want to get in touch about any of the detail, please do. I'm just going to pull out what I think are the key points, starting off with North East Lincolnshire. we've seen falls in both life expectancy and healthy life expectancy in the last decade in North East Lincolnshire, and 5 of our wards are considerably below the place average and the England averages, and those are East Marsh, West Marsh, South Sydney, Sussex and Heneage. And this is partly associated with people in socially deprived communities, what we describe as being old before their time, and often developing chronic conditions a decade before people in other areas. There are wide disparities in cardiovascular disease, in respiratory disease and in cancer, and I'll go on to that later on in my presentation. And almost 40% of 11-year-olds are overweight or obese. We weigh and measure children in reception and in year 6, and we see a huge increase in overweight and obese children in that time during primary school. Schools and education are a crucial part of our health and well-being. And tragically, we've seen unprecedented levels of suspected suicide in North East Lincolnshire over the last 4 years. Next slide, Simon, please. Almost a fifth of households in North East Lincolnshire are living in fuel poverty. I went on something called a ward walk on Monday evening with some elected members and saw that for myself, the standard of properties that some of our residents are living in. And we're projecting some major demographic challenges in the future, which will really impact on your services. And just one of those challenges is a 30% increase in the number of people over 80 in the next 10 years. It's going to place enormous strain on services, and I think that's something that we can talk about at another time. I've got a huge health needs assessment that I could share that you might be interested in. Next slide, please. So a little bit more information here about life expectancy at birth for men and women. The top of the slide at the left hand side is men, and the women is on the right hand side, and you can see from that that both are decreasing, but more so for women, which definitely needs further explanation. I don't know why that is at the moment, so we're commissioning a piece of work to look at that further. The bottom graph on the left hand side, that shows the increase in under 75 mortality from all causes in North East Lincolnshire, and I'll break that down in the slides coming up. Next one, Simon, please. So I do appreciate there's a lot of data on the slides because there's a lot of information I want to share, and I am flying through. So, just say again, please contact me afterwards, or happy to answer any questions this afternoon. In terms of health inequalities, for a fairly small geographical area, there's huge variation in life expectancy in North East Lincolnshire. So males born in East Marsh have a life expectancy on average of 70, travel a short journey to Humberston and New Waltham, and that increases to 82. So in a very small geographical distance, there's a 12-year inequality in life expectancy, and there's a similar pattern for women. It's a 10-year gap for women. Next slide, please. So I've also focused on healthy life expectancy. So life expectancy is how long we expect someone to live. Healthy life expectancy is the age that someone will develop a chronic condition, which means that they will need services that you and your colleagues provide. It often means that they are no longer economically active, and it has a huge impact on their quality of life and the pressures that health and social care services face. And some of these figures are really shocking. So male healthy life expectancy in the most deprived parts of North East Lincolnshire is 52, and it's 51 for women, with a gap of 16 years between the most affluent and deprived wards. So the data so far, I hope, is painting the picture that depending on where you are born, being born in more deprived areas means you will live a shorter life, and you will live a longer part of that life in ill health, and those are the inequalities that me and my colleagues are trying to tackle, but we can only do that in partnership. So the next slide, I'll move on to North Lincolnshire. Equivalent data, but I won't repeat anything where the messages are the same. Life expectancy has remained relatively stable for both men and women over the last decade in North Lincolnshire. However, there remains a 10-year gap between the most deprived and the most affluent wards. 10-year gap for men, 8-year gap for women, which demonstrates although it's remained relatively stable, we still have significant health inequalities in North Lincolnshire. Next slide, please. Similar to North East Lincolnshire, over 36% of 11-year-olds are overweight or obese, and that rises to 71% in adults. Our under 18 conception rate has increased, and still over 12% of mothers are still smoking at time of delivery of their baby. Our smoking prevalence in North Lincolnshire remains high, and our quit rates are too low. Again, ageing population and our rate of hip fractures in over 65s is high. Next slide, I'll skip over, Simon, please, if I may, because it's got similar issues to what I've described for North East Lincolnshire. Thank you. So this slide, although this is the life expectancy at birth for men and women again, so men on the left, women on the right, and although it has remained fairly stable, we have seen a decrease in men over the last few years, which is illustrated on that slide on the left-hand side. Next slide, please. Again, this looks at healthy life expectancy for residents in North Lincolnshire. I'm just pulling out the key points here. It's lowest for men born and living in Brumby in North Lincolnshire, and for women it's Ashby Lakeside. And I'd be really interested to hear if you see some of this in your work as well. Next slide, please. In terms of healthy life expectancy, very similar figures to North East Lincolnshire. For men born in the most deprived parts of North Lincolnshire, their healthy life expectancy is 52, and for women it's 51. A bigger gap here than we have in North East Lincolnshire of 18 years between the most affluent and the most deprived wards, which again demonstrates the significant health inequalities that we have. Next slide, please. So this one, I've covered it earlier, but illustrates the increase in under 75 mortality, and I am going to break that down into a couple of the major conditions with a focus on diseases that are preventable. So I will come back to that one. On the next slide, please, Simon, thank you. This one is under 75 mortality rates from all preventable circulatory diseases. And after several years of decline, the rates are now increasing in both North Lincolnshire and North East Lincolnshire. Next slide, please. This is the same under 75 mortality rate for cancer, and again consistently higher across Northern Lincolnshire than the England average. Next slide, please. This one looks at liver disease, consistently increasing across both areas. This is likely to be a huge challenge for us, and we need to act now to reduce that trend. Next slide, please. And finally, in terms of the graphs, this is a respiratory disease considered preventable. Again, similar picture, consistently higher. So, what can we do as a system to turn some of this data around? Next slide, please. As a Director of Public Health, I have a statutory duty every year to produce an annual report. Directors of Public Health can choose what their annual report is focused on. And for my first Northern Lincolnshire report, I wanted to focus on what makes us healthy and follow on some of the work that's been done by the Health Foundation, in that 80% of our good health is influenced by the wider determinants of health. And that's what I want to focus on as Director of Public Health in Northern Lincolnshire. My report has 8 chapters. And those 8 chapters focus on friends, family and community, the food we eat, money and resources, housing, transport, education and skills, good work and our surroundings. And only by ensuring health and health inequalities are weaved throughout those themes, we will struggle to turn some of this data around. So my report is the role everyone has across our systems and across our place in improving health and improving the life chances of people that live in Northern Lincolnshire. The report will be overseen by the Health and Wellbeing Board in North Lincolnshire and in North East Lincolnshire. And again, I'd be really happy to come back and talk about it in more detail. The next slide, Simon, please, summarises the recommendations that are in the DPH annual report. I'm not going to read those now, but we will deliver against those recommendations in the next 12 months, and I'll report back in my second annual report in terms of the progress that we've made. Next slide, please. So my last few slides focus on some of the great work we're already doing with NLaG colleagues, including a lot of work with midwifery and with smoking at time of delivery, and your teams throughout the sites, and we're making some really good progress. The next slide has got a couple of other examples. Our oral health promotion service is delivered by NLaG, and we're working in partnership on the delivery of fluoride varnish for areas most in need. I've not touched on oral health in children in my presentation, but we see very high numbers of children needing general anaesthetic for tooth extraction. The last few slides I'm not going to dwell on in the interest of time, but it gives you a flavour of, if you wouldn't mind moving on, Simon, just a couple of examples of what other areas have done working with public health and acute trusts. So I've included examples from Barnsley, from Cheshire and Merseyside, Coventry and Warwickshire and Leicester. I'm not going to go through them now, but I think there's certainly things on here that are worth exploring further. And just to end in terms of what are our next steps, I will be meeting with senior colleagues across NLaG, holding a joint workshop between our senior teams to look at those examples that were on the previous slide and develop a joint plan focusing on what our shared priorities are. I appreciate I've flown through an awful lot of data there. I hope it's been helpful. Really happy for the slides to be shared and to continue this conversation outside of this afternoon. But finally, just thank you again for giving me the opportunity to join, and I hope everyone's taken something away from it. Thank you.
Thank you so much, Diane. That's been an excellent presentation, and for colleagues and members on the call, I'd certainly commend Diane's report to you. It's very readable. It's got some really key messages in there, and I think we need to be on a partnership journey on this. Diane, I think my question for you, really, I suppose, is for all of us on this call. What would you like to see changing in terms of what we can do ourselves to try and either behave differently or promote health, to try and get people to, or get this imbalance in life expectancy and healthy life expectancy more balanced? So have you got any final thoughts for us on that?
Yeah, it's a great question, and I could talk for hours about it. I think there's some very strategic things we can do in terms of linking NLaG into our health and wellbeing boards, to have conversations about some of this where we do talk about housing and transport and the impact on health. There are some very practical things we can do. So one of the chapters in my annual report is around the food we eat, and we're looking at a healthy weight declaration for Northern Lincolnshire. Very, very early days, but I think it was Jonathan who said how many people are employed as part of your trust. And looking at the workforce and the food that we all eat. I'm sure many are residents across Northern Lincolnshire, and that might be a really good starting place for us to do something with our workforce. But I think us starting to have the conversation about particularly people that you see admitted and readmitted, and what some of those social reasons are, and starting to share our data a little bit more as well, and just starting this conversation is really positive. So, you know, if you might invite me back in 12 months' time, we could talk about some of the things that we've done together.
Yeah, okay, that's really helpful, Diane. And noted is the arrangement you've got with Nick, pardon me, Nick Cross and the wider leadership team, so you can put some practical steps into there. But I think you're right. The size of our organisations is pretty huge, and influencing from within, I think, is probably a good idea for us to try and think about how we can do that. A healthy weight declaration. When you're looking at me, I'm afraid I could be one of those victims who ought to be showing an example here, so I do take that message on board. But that's been great to be able to connect in this forum, and we need to make this as the starting point for a thriving relationship. I'm sure that that will be the case. I'm just looking in the Q&A here. Let me just check whether there's anything that's arrived in as a result of what you've said, and I'm not sure I've got anything at the moment, but it's been really helpful. And again, just to commend Diane's report to everybody, it's a really good read and hits home on really important things. So thank you so much, Diane, for that, and I'm sure we'll be seeing you on a regular basis going forward. So if I can just take a little a moment just to correct myself from the beginning of this meeting. I was in such a rush of excitement to listen to what Jonathan was going to say. I actually omitted to mention a couple of formalities. One is the apologies that have been tabled for this meeting, and can I just get you, Alison, to read those out, please, for the record, if that's okay.
Yes, thank you, Sean. So we've had apologies from our governors, Paula Ashcroft due to annual leave, and David James and Shivnand due to work commitments. In terms of our executive team, we've had apologies from Paul Bytheway and Ivan McConnell for annual leave, and Simon Nearney due to work commitments. In terms of our non-exec directors, we've had apologies from Linda Jackson and Jill Ponder due to annual leave, and from Sue Liebird due to work commitments.
Okay, thank you, Alison. So my apologies for not having covered that at the beginning. We normally run through declarations of interest as part of the protocol for this, but unless anybody wants to show hands to say that what they've heard or what they are about to hear is any sort of risk of any conflict, then I'll assume that we're okay in that from that perspective, if that's okay. The other item is to for this meeting to actually receive the approved minutes of the previous meeting, which we held back on the 1st of February this year. Members may remember that the meeting on the 1st of February was actually delayed to that point because of delays in appointing auditors. But now, so we're only 7 months on from that meeting for 22-23. So those minutes are there in the pack in public. The reference at COG brackets 24045. They're not for approval in this meeting because they've actually been approved by the Council of Governors. So they're therefore noting and to be received by the meeting. So my apologies for not having covered that at the beginning. I hope I haven't put you to sleep by referring to them at this point in time. And again, just to reiterate, thanks to Diane for a very insightful presentation on public health, which is so important to all of us. Next, so can I move on to the final business item, which is from Alison Hurley, our Deputy Director of Assurance, who's going to let us know about the latest position on the governor elections, which are coming up in November. So let me hand over to you, Alison. Thank you.
Thank you, Sean. Yes, so I just wanted to take the opportunity really to make you aware that we have 9 governor seats. If we can have the next slide, please, Simon. We have 9 governor seats up for election in our annual governor elections, and we're looking for prospective governors who are passionate about health and social care in our local communities. You can see from this slide we've got 5 constituencies, and each constituency has vacancies at present. So we have 1 seat in East and West Lindsey, 3 in Goole and Howdenshire, 1 in North East Lincolnshire, 2 for North Lincolnshire, and 2 seats for our staff governors. So we, if you just might move to the next slide, please, Simon. Thank you. So as part of our elections timetable, we're currently undertaking the process of nomination. So we're holding roadshows, and those roadshows have been held at each site on an early evening. We have 2 coming up shortly, which are going to be virtual ones, so people can attend those if they wish. And that's on Tuesday, the 17th of September, 2 till 3, and Wednesday, the 18th of September, 6 till 7. If people don't book on these, it is worth just noting that they won't go ahead. So we do need bookings if you wish to attend those, please. The details to be able to access those and book onto them are just on our Trust website, which is nlg.nhs.net, and full details are provided there. Obviously, the roadshows are quite important for most people because it gives you the opportunity to find out more about the Trust, the Governor role, and the commitments that are required in terms of time, meetings, and the elements that the Governors cover. It also gives people that opportunity to ask any questions, which often people find quite helpful. But if necessary, if you can't attend those 2 remaining Governor roadshows, I'm still happy to take a phone call and help and advise if needed. Obviously, we can provide full details about the Governor role on those roadshows, but if anybody wants to contact me, that my details are on the website as well. I think that's all we really need to cover for now, but we do hope to hear from prospective governors going forward and hope we can actually elect to all of our governor seats which are vacant.
Thank you, Alison. So for anybody who may be in contact with members of the public who may be interested in a role as a governor, they are really responsible roles and can make a real difference to the way we shape our services. So please promote those vacancies if you're in this situation where you're in contact with people who may be interested. So let me just go back to the Q&A here. David, how do we know David as a governor? You've declared your interest in your sort of local authority role, so that's helpful to hear that. But you also mentioned something about I think you're talking about public health information around the Goole and East Yorkshire area. I'm assuming that's the case. And a question, so that's something for Diane then. And then I think, David, you mentioned about Goole itself and the prospects and intentions for Goole. So Diane, have you got anything to say about the public health data for that patch? I'm pretty sure that there's similar standard of information will be available. If you can direct people towards it today, that might be helpful, please.
Absolutely. I've seen Councillor Howard's question, and what I can do is that the data should absolutely be available. So my counterpart, Andy Kingdom, Director of Public Health at East Riding, I can get in touch with him outside of this meeting. I'll share the slides that I've produced and ask if Andy or a member of his team could replicate the same information for East Riding at the request of Councillor Howard. So I'm very happy to take that away as an action.
Yeah, thank you very much, Diane. And Jonathan, can I just ask you to see if you can shed any light on David's question around the general view of the future of the Goole Centre, please?
Chairman, thank you. David, thank you very much indeed for your question. So as we continue to harmonise across the new group, Northern Lincolnshire and Goole NHS Foundation Trust and Hull University Teaching Hospitals, in real terms, we have 5 physical hospital sites. So Grimsby, Scunthorpe, Goole, Hull Royal Infirmary and Castle Hill Hospital. And we also have changing pathways of care. At this point in time, and for quite a long period leading up to this point, we use Goole in a very different manner to the manner it was originally envisaged maybe 20 years ago when it was constructed. So we have very, very few inpatients in the Gould facility, but we do have strong access for some aspects of outpatient service and ophthalmology outpatient service, some of our day case services, and our partnered urgent treatment centre. So whilst we're working through the future direction of the wider group organisation as part of framing our strategic intentions for the next 3 to 5 years, I think it is right and proper that with partners and interested members, we continue to challenge whether or not all aspects of our organisation are appropriate, right-sized, right-shaped, and providing the right functional services to the demands of our patients. So I can very much say that as we move forward over the next 6, 12, 18 months, we'll be seeking to engage both with elected members, governor members, and the wider population across all of our areas of service and all of our physical geographies, not just Gould, but all of our physical geographies around the future state of physical environment and service accessibility moving forward. So I hope that opens an avenue for conversation, David, but if there's something more specific and pressing that you have in mind, the chairman and I are more than happy to have conversations outside this public forum. Thank you.
Thank you, Jonathan. So the door's open for further conversation. David, there's nothing to publish publicly here and now today, but Jonathan has mentioned there that as is his job and the job of this, the boards of both trusts to continually scrutinise the effectiveness of the services we provide, and with a view to high quality patient care and the best use of the public purse. So that's our continuous challenge. But apart from that, nothing more to say about that today. So if I can just move us on to the final item, it's just really a second one. Further questions from members of the public or anybody on the line today. If we just a last call for that. Julie Bealby. Hi, Julie. You've asked for data for East and West Lindsey councils by ward. Again, Diane, could you help us out with that, please? Oh, so you've already, yeah, okay. You're going to get in touch with Derek then. Thank you very much. Thanks very much. So, Julie, that will be helpful. Right. So, I suppose finally, a couple of thoughts from me. Firstly, is whether members on this call have found this format to be effective and useful as a way of conducting an annual general meeting. We did do this for the first time back in February. It is a way of at least allowing access to a very large amount of the public who perhaps otherwise wouldn't be able to attend physically these meetings. So very happy to take any views either now or as we in the near future. I think most of us will feel that this is probably the way forward for these types of forums. But again, anybody who's got a different approach or different ideas would be very welcome. And I just ask for those thoughts to be channeled through to Alison Hurley, if that's okay. If you don't want to make any comment now, but you can certainly do that in the future. Secondly, I suppose just to reflect back on the agenda and the amount of information that's been presented today, and it's really a pretty momentous and significant challenge that we face and a privilege to be part of the NHS. We have a lot of responsibility. I hope members of the public will recognise that we do take this very seriously. We know we have to do our best for patients, look after our staff and look after the public purse, and all of those things are continuous challenges. And as Diane has said in her presentation, the influences on health are not are multifaceted, and we are in the acute sector tend to be the recipients of lots of influences that we're responding to rather than necessarily influencing upstream. Jonathan's mentioned the issue about getting our local emergency performance to be better than it is, and that again is not only an issue about us doing really well when we get patients in our premises, but also the prevention agenda upstream, and how do we handle better social care provision downstream. So everything's connected to everything else, really, I think is the message I've got about this, and we cannot think of ourselves in isolation. More and more, we need to be thinking about how we can partner in stronger, more fulfilling ways to get the best out of the provision that we've got. And this trust and our group is very mindful of our position in trying to influence and behave as a good partner. It's really important for us that we remind ourselves about that. We have some fantastic people. You'll have heard from lots of people here today who are totally committed to this cause. We have under our care 19,000 souls who have come to work to be the best of humanity at work every day, which is caring for our patients, and it's a privilege to be part of that movement. We really do need to bring everything we can to the party, and at the same time look after ourselves, look after our people, and enjoy doing what we're doing, because it is actually, when you're out in the field, a really joyful experience. Despite the pressures we've got, we have some fantastic examples of great care happening every day. So I just want to commend those thoughts to everybody to make sure that wherever we do get a chance to interface with our staff, we do show some real appreciation, because they're the ones that make a difference to patients every day and will leave lasting memories of their impact with the people they're treating. So
So I think we've had a wee bit of a technical hit there with the chairman just passing appreciation, celebration of our staff's contribution.
Points, colleagues, again
I think we might be losing. Sorry, I think we might be having one or two problems now with Sean. So let me step in, colleagues. Thank you very much indeed for attending not only our review, but very much a celebration of success over the last 12 months period. We apologise for that little technical glitch. On behalf of the chairman, myself, the wider executive team, our thanks go to the governors and the wider population base for their continued and unfettered support of Northern Lincolnshire and Goole NHS Foundation Trust. I'm sure the next 12 months will continue to be a really exciting time for our staff, our services, and ultimately our communities and patients. And we very much look forward to you joining us in around about 12 months' time for a similar opportunity to share with you our successes and reflections on the 24-25 operating year. So on behalf of the chairman and myself, go well, go safely, and have a very pleasant afternoon. Thank you very much indeed for joining us today. Thank you.
Thank you for stepping in, Jonathan. I'm back in the room, but you couldn't have wrapped it up in any better than that. Thank you so much, and thank you, everybody. And again, enjoy the rest of your day, and we look forward to seeing you soon. Thank you.
Thank you.